at the outset, I will be thanking the DARE for giving me this opportunity to discuss about MASH. This terminology is recently changed, as we were previously using the terminology like hepatitis. Now they have changed the terminology to metabolic dysfunction associated steatohepatitis or metabolic dysfunction associated fatty liver disease or liver disease. So I will be speaking a few basics, not going into the depths of hepatology or gastroenterology, as most of us are the physicians. I will be trying to answer these questions. First of all, what is this MASH or MAFLD? Why is it important for us? And how to go about it once we see these findings? And when to treat, and how to treat, and how to follow up. So, as I said, whenever we see fat in the liver, commonly when we do ultrasounds for different reasons, sometimes patients will come to us with a report showing that there is fatty liver disease. Whenever the percentage of fat is more than 5% within the liver, generally ultrasounds pick up that the liver is having fat. So there are two important factors that we need to see. One is whether there is history of significant alcohol intake or not. Second important thing that we need to see is, are there any cardiometabolic risk factors? These are the two things once we see any patient who comes with a ultrasound report of fatty liver. If the alcohol intake is significant, which sometimes they have given a criteria of taking per day more than 20 grams in women and more than 30 grams in a men, then we'll be thinking more in terms of alcoholic liver disease. If there is one or more cardiometabolic risk factors, which I will be coming in the next slide, if they are there, then we should be thinking that it is because of metabolic dysfunction related fatty liver disease. Sometimes there can be a combination of both the things. Whenever there is significant alcohol intake, as well as there are significant cardiometabolic risk factors, then it can be a combination of these two. So commonly what we see is whether the fatty liver is either because of metabolic dysfunction related or because of alcohol related. Sometimes we see because of some other conditions, like because of infections and Wilson's disease, drug-induced, and other things are rarity. What are these cardiometabolic risk factors which will say that it is metabolic dysfunction? These are, one is BMI, if it is more than 23, waist size, particularly in the Indians, more than 90, or more than 80 in women. The other criteria which is commonly used is the waist size of any person at the navel should be less than 1/2 of the height, if you take it in centimeters, right? If the waist size is more than half of the height, that means there is significant visceral obesity in the abdomen. That is also one of the risk factors that shows that it is there. If the blood pressure is more than 130 or 85, or if the triglycerides, whenever the patient's report shows that it is more than 150, and if the hemoglobin A1C has crossed 5.6, or if the HDL value is less than 39 in case of men, and if it is less than in case of 50, if any one of these factors are there, then that shows that the person is metabolically dysfunctional. And if he is also having fat in the ultrasound, that means he is having metabolic dysfunction associated fatty liver disease. So what contributes to fat accumulation in these people who are having this metabolic dysfunction? There are multiple factors, but the genetics as well as epigenetics are mainly, as we know, hyperinsulinemia, hypertriglyceridemia, visceral obesity, as I was discussing. There is also the role of gut dysbiosis, bad bacteria increasing within the GIT, and unhealthy food habits, alcohol, and excess intake of processed foods. All these will be contributing towards the fat accumulation within the liver. So, if there is fat, why should we be concerned? Why it is important to us? Because it has two bifurcations. The fat within the liver can damage the liver, as well as it can also involve the other different organs. If you see the fat in the liver over a period of time, it can lead to steatohepatitis. That means inflammation is occurring in the patients. There can be developing into fibrosis. They can convert into cirrhosis and sometimes hepatocellular carcinoma. And in the coming years, alcohol and metabolic dysfunction associated fatty liver disease is going to be the #1 cause for liver transplantation, as the other things like hepatitis B and C are coming down. The other thing is not only the liver, once we see fat within the liver and the person is having one of the cardiac metabolic risk factors, these people are also having the risk of having all the other systemic involvement. These people will have more likely to develop hypertension, dyslipidemia, gallstones, renal stones, renal failure, cardiac events, strokes, PCOS, and all this. The fat in the liver doesn't say that it is only causing damage to the liver, it can also involve any other organs as shown over here. So whenever the patient comes, we have to not only look at the liver, but we have to see the patient as a whole. So how to go about it once I see fat within the liver on ultrasound or a patient is having any abnormal LFT? So there are different methods, but I have simplified. There are so many scoring systems. The common scoring system that we use is what is called as FIB4 scoring system. A simple CBP and LFT using calculators that are there will give us the score of FIB4, which is a standard scoring that we use in the MASH. And second thing that we should be aware is something which is called as elastography, liver elastography or fibroscan. This is a type of a ultrasound technology wherein a small frequency ultrasound waves are used to look for the stiffness of the liver. The difference between conventional ultrasound and liver elastography is it will say about the elasticity of the liver, right? These are the two investigations. One is CBP, LFT and liver elastography, which will help us to grade whether the patient, how to go about for these patients. So whenever the FIB score is higher, more than 1.3, if it is less than 1.3, these patients will be given counseling about the lifestyle changes and will be followed up. If he is having more than 2.67, that means the patient is definitely having significant liver damage and we will be involving multidisciplinary to look for the other organs and he will be given medications and going about. But if the FIB score is somewhere between 1.3 to 2.67, wherein we use the fibroscan to look for whether there is increased fibrosis or less fibrosis. If there is increased fibrosis, we will be aggressive in treating these patients. If there is less fibrosis, then we'll be working more on the lifestyle changes and we'll be following with these patients. And now coming how we generally treat, I'm not going to the depths of treating, but superficially we'll be dealing with that one. So treatment, the core of the treatment is lifestyle rather than the medications, right? So lifestyle changes, which involves the diet, the exercise, mainly apart from stress management and sleep as Shyam was discussing, the pharmaceuticals or the medicines that we use, what are the endoscopic approaches and what are the surgical approaches. So what weight loss goal is important? It is seen that whenever there's 5% reduction is there, these patients will have slightly improvement in everything. But if the patient can achieve up to 10% of weight reduction from his baseline weight, then he will also have improvement in his inflammation improvement, as well as he will have improvement in his fibrosis improvement. So at least a 10% of weight reduction should be the goal for the patients who have fatty liver disease and who will be requiring the treatment. So which diet is best? Of all the diets that have been studied, the Mediterranean diet has been shown to be giving the best results for these people who are having cardiometabolic risk factors. So what is the core of this Mediterranean diet? It is good amount of wholesome foods, fruits, vegetables, nuts, and seafoods, as well as olive oil. So when compared to the food, olive oil is the core of Mediterranean diet. So the changes which we can advise for our patients, taking a lot of fish rather than the red meat, fermented dairy in the form of curd or yogurts, taking a lot of fruits, lots of nuts, green leafy vegetables, herbs, vegetables, and a lot of legumes. Legumes are also the core of the Mediterranean diet, and the grains should be the wholesome and some lean protein. These are the core of Mediterranean diet. If such type of a diet is being advised for these patients, it makes a lot of difference in their treatment. And minimizing ultra-processed foods, which are so-called the fast foods, which most of us know, the French fries, the burgers, the pizzas, and donuts, etc. And it is shown in a few studies that coffee is good to the liver. So 1 or 2 cups of a coffee for these patients is good, but this coffee should be preferably without much of a sugar. Stopping of smoking and stopping of alcohol, if the patient is consuming, will also help him in the long run. Second thing is exercise. So what type of exercises should we advise to these patients and how to go about them? Aerobic exercise, depending upon them, whether walking, jogging, swimming, cycling, any type of aerobic exercise will have the benefit. Not just the aerobic exercises, but also resistance training has a lot of benefit of these patients, depending upon them, whether the squats, push-ups, or simply using the resistance bands has been shown to be much useful in these patients. There's something which we call that as high intensity intermittent training. It's a type of intermittently increasing the heart rate to the maximum level and trying to get it down. Even this has been shown to be beneficial. So for which patient, which type of exercises? It has been shown that a combination of aerobic as well as resistance training will be more beneficial for these patients. But most important is it can't be fitting to each and every patient. We need to tailor the exercises depending upon the patient's age, gender, their flexibility, their comfortability, whether they want to do at home or they can, depending upon that one, we need to do a tailored or customized exercise plan for these people. So what is the duration of exercises that we should be advising for these people? It is shown that at least 150 minutes in a week, if it is a moderate exercise like walking or brisk walking or jogging, or 75 minutes of high intensity per week is mandatory for these people. So this is what in short, but I think that it can't be seen on this thing. Before going to pharmacotherapy, what I need to emphasize is how we counsel these patients is if they are having fat within the liver, I simply say to the patient that it is something like you're keeping a thief within your home. At some day or the other day, he's going to do a theft, whether it will be a small theft or a larger theft. The early you remove the thief, the better it is for you, because it can cause a cardiac event, or it can cause damage to your liver, or it can suddenly cause a renal pain causing renal stone, or it can cause gallstone, or it can push you to hypertriglyceridemia, all these things. So we should emphasize for all the people who are having fatty liver as if they are keeping a thief within their body, and sometime or the other he's going to rob your health. So the earlier you run this thief or the robber, the better for you. Coming to the pharmacotherapy, there are many drugs, but in the proven and phase 3 trials recently, this drug which is by name resmetirom, which is thyroid hormone receptor beta agonist. It particularly acts within the hepatocytes beta receptor, and it causes lipolysis. So it reduces the triglyceride content within the liver, and by decreasing the fat content within the liver, it has been shown to be having beneficial effect even up to the fibrosis level. This was a study which was published in February, which has shown that this drug at 80 to 100 milligrams has been shown to be beneficial both in inflammation improvement as well as the fibrosis improvement. Other drugs, there are multiple other drugs in small studies as well as the larger studies and meta-analysis. Particularly commonly drugs that we use here are vitamin E, because it has antioxidant property, anti-inflammatory property, and as well as antibiotic property. So it helps in reducing the fibrosis once it is given to these patients. Sometimes in diabetic patients with hypertriglyceridemia, we also use arglitazar. Again, it has a positive effect on the liver. Pioglitazine can be used in diabetic patients. I'm not going into the depths of the drugs. GLP-1 agonists like liraglutide and semaglutide can also be used in these patients. There are indications and durations, but none of the drugs will be so useful as the lifestyle changes. Again, we need to emphasize on that one. And drugs we will be using depending upon the patient's liver status and their diabetic status and other comorbidities. endoscopic thing, because I'm a gastroenterologist, we'll be going into that one, but this evidence is not robust. But there are a few encouraging things wherein endoscopic ablation of duodenal mucosa is done, and once the resurfacing of the mucosa happens, the DLP, it acts more or less like a bypassing by bariatric surgery, and there have been case reports as well as the small studies which shows that duodenal mucosal resurfacing will work both in diabetics as well as in the people with fatty liver disease. In the same way, bypassing this one through endoscopic ultrasound guidedly, directly we can puncture into the jejunum and we can create a gastrojejunostomy as it was done by the surgeons through a minimal invasive thing, and it also helps in these people, and studies are going on even in these things. Like the surgeons do the sleeve gastrectomy endoscopically, also there are devices through which the volume of the stomach can be compressed into a small, like a sleeve gastrectomy, and this has also been useful in a few patients who are obese as well as in the patients who are having diabetes. Again, studies are going. These are all naming and initial stages, but down the line they may be coming. And bariatric surgeries, particularly in the patients who are obese, morbidly obese, this will not only help in the fatty liver as well as significant fibrosis, but sometimes in few selected cases of cirrhosis also, these can be offered if they are morbidly obese and having other conditions. So in short, so whenever there is fatty liver disease or inflammation, whether the patient is having cirrhosis or not cirrhosis, depending upon that one we will be managing. If the patient is not having cirrhosis, the drug that we commonly, which has better evidence is resmetirom, but we also use other drugs like vitamin E, sometimes omega-3 fatty acids, sometimes we use sargitolazar. And if the patient is having diabetic, GLP-1A receptor agonists are better. Sometimes SGLT2 inhibitors can be used. Metformin is having some role. If the patient is having dyslipidemia, statins, there is some role but not robust. Sometimes sargitolazar can be used. If the patients are obese, again, GLP-1 receptor agonists as well as bariatric interventions can be done. So these are into the depths of how the patients will be there. If any questions are there, I will be happy to take up this one. With this, I stop my study, this presentation, and I want more questions to be asked from the guardians. Thank you.
Prevention of fatty liver disease.
Again, ma'am, it's like one of the initial slides I have shown. It's a combination of the amount of calories, type of calories that we take, the gut bacteria that we have, the physical activity that we do, and the lifestyle. So it again boils down to lifestyle, right? For example, we particularly are predominantly carbohydrate-rich eating people, and because of sedentary lifestyles, lack of exercise, and eating of more processed food, bringing in more bad bacteria or bad microbiome within the intestines, all these things will be contributing to our fat within the liver.
So not everyone is more people are suffering from.
Yeah, in our hall, almost 70% of us are having 70% of them. So we are prone to have all these things if we don't take care of our health down the line.
Congratulations, Dr.
Thank
Abdul Khalique.
you.
As expected from you, very lucid to the point talk. I really appreciate. Just, I am not a master in this subject. There are master
Yeah.
co-chairpersons. There are better people to. I just dropped from the sky to chair your session.
Thank you.
My one concern is, thank God Muslims are not consuming the alcohol as compared to others. But unfortunately, we have adopted the culture of late marriages, midnight biryanis. I'm really worried. Almost every patient will have fatty liver in the population. And the waste what you have said, it is also my good. So anything should be done at a war front to stop our people from having these late celebrations. And not only that, the future generation, the children will not be having proper schooling on the next 1 week when the mother attends that marriages. So I think they should take this aspect also to do something to prevent this. That is one thing I want to say. Second
Well,
thing is most of the women, what when we say lose weight, they are saying that we are not able to have regular walking. We are all constrained to the houses. That is also one point, the practical point. They are not able to have any access to the walking or exercise. Thank you so much.
Regarding your questions, ma'am, yes, once in a while or regular eating in the functions or outside food definitely contributes, but more than that one, it's our daily routine that has a significant contribution. So obviously, according to Sunnah as well as according to this one, medical science also, the life should go according to circadian rhythm. Early rising, early weaning off. If I ask in a hall who are going to close their practice by Maghrib, I think that one or two along with me. Other than that one, they will say no. That is the time where we actually start our practice. So these are bound to happen if you don't take care of the things. And in the same way, as I was, and we all experience, though the Western literature hasn't yet shown, but during the month of Ramadan, when we fast as well as our patients fast, we see that there is significant decrease in the visceral obesity, right? That, and now in the Western population, it is being picked up a fancy or fantasy which is called as intermittent fasting, right? The best type of fasting is what is dry fasting, which we do for a month long together. But even the intermittent fasting principles work well for all the people who are having metabolic dysfunctions. Like eating window should be 9 hours or 10 hours, at least 14 to 15 hours of complete fasting according to circadian rhythms will help to limit the amount of fat accumulation within the viscera. That is one of the easiest thing to do. Second thing which we commonly ask our patients is rather than having one major meal or two major meals, it's always better during that eating period have 3 or 4 small meals. Because once we take a larger meal, whenever, as we are predominantly carbohydrate rich food intake, once the carbohydrate or glucose spikes beyond the threshold, that converts into triglycerides. Rather than having one major meal, it's always better to have 3 small meals, but that should be within that eating period of 9 hours. Third thing which can be done is while eating, it's always better to have a glass of water before we start our food, and always include raw food in the form of either fruits or salads as was shown in the Mediterranean diet, that it should at least have 20 to 25% of our plate. And protein consumption should go up predominantly either in the vegetarian proteins like the pulses or paneer or tofu, or if non-vegetarian we are taking, predominantly we stick on to either eggs or fish or poultry, and once in a while red meat. The red meat consumption should come down. Other sources of lean protein should increase. The complex carbohydrates in the form of vegetables, curries, green leafy vegetables should increase. And the carbs, whether it is rice or roti, should not be more than 1/4 of your plate. 1/4 should be the salad, 1/4 should be your protein, 1/4 should be complex carbohydrates, and refined carbs or rice and roti should be 1/4 of your plate. And it is also shown that if we take a small walk for about 10 minutes after we have our food, or if we can't walk, at least if we move our legs for about 10 minutes consistently after food, the glucose spikes will be less and the triglyceride formation after eating food will be low. So these are small things which we can incorporate in our lives, as well as we say to our patients to incorporate into them.
One question, sir.
Yes.
What is the rationale behind suggesting fibroscan in comparison to ultrasound and elastography? Nowadays, we have got high-end ultrasound machines which cover large, areas, also giving fat percentage in that. So,
see, these are two different technologies that are being used. This is vibration-controlled methodology, which is a fibroscan, and most of the studies and better accuracy is given by this one when compared to the shear wave thing that is seen by the software that is incorporated into the ultrasounds. So most of the studies that are there, as well as the guidelines, they have taken the standard as fibroscan rather than a plain ultrasound.
what do you prefer? Because fibroscan?
Fibroscan.
It won't cover the entire liver.
No, first we do ultrasound. We document that he is having fatty liver, and while doing ultrasound, we look for other subtle things, whether the patient is having splenomegaly, whether the portal vein is dilated, how is the outline of the liver, whether it is irregular, is the echo texture abnormal, right? If we don't have any clear-cut evidence of fibrosis or secondary portal hypertension, in such cases, we go ahead with a fibroscan and try to see whether he is having significant fibrosis or no fibrosis. Depending upon that one, the treatment algorithms will be coming.
Very nice presentation, sir. I would also like to emphasize the group of population who comes with drug-induced liver injury, which mimics the whole fatty liver thing, and that also has to be controlled to the population. If we have to counsel using whatever the herbal drugs which are being used,
Yes.
they are also very good.
I have one more questions from the audience. Yes, sir.
Whenever we get a USG agreement that what you have done, somewhere in the body, but one finding will be there, fatty liver, in almost every report.
That's what the epidemic is.
Should we treat every patient with fatty liver?
They have to be sensitized that your fatty. I mean, many of the people who come to me and they say that this was shown to other doctor, other physician. They said, "ये तो सब में रहता है, जाने दो कोई बात नहीं," right? But that is not the case. This is actually, if suddenly the patient knows that he has become diabetic, then he says, "Sir, कुछ बोलो, I don't want to start medicines. What exercise I should do? What I should do?" This is something which starts few years before a person becoming diabetic or hypertensive or putting in a stent in a heart or developing a gallstone or renal stone. So once that starts, we need to sensitize the patient that the things are going wrong. If a lifestyle goes in the same way, you're going to land up on these things and these things. So if you doesn't want to land up in that one, start working on your lifestyle right from now. That is what we need to emphasize on these people. Yes.
When do you actually prescribe pharmacotherapy?
Yeah. In pharmacotherapy, one thing is whenever the liver enzymes are elevated and when we don't see any other reason for elevation of liver enzymes, along with that one, if there is significant fibrosis, more than F2 on fibroscan, then we, along with the lifestyle changes, we go ahead with pharmacotherapy. When the patient is having only liver enzymes elevated, but borderline, if the patient is having less fibrosis, say he's having F1 fibrosis or no fibrosis, we try to look for other causes of increased in liver enzymes. If we don't find, then also we give for a shorter duration the pharmacotherapy and see how he responds. But more than pharmacotherapy, we have to again emphasize that this is just a smaller thing, maybe 10% or 20%, 80% you need to work in reducing your weight to 10%. And we need to reassess them, and the reassessment of fatty liver is not like in a month or two. The minimum period is 6 months to 1 year, wherein the patients will be having mild elevation in the liver enzymes. So we'll be adding one medicine or the other medicine, and we'll be emphasizing repeatedly to meet a nutritionist and work so that his weight comes down.
Fatty liver can be reversed.
Yes,
Fatty liver can be reversed.
yes, even fibrosis can be reversed.
Grade 1.
Even fibrosis, even up to F3, F4 fibrosis can be reversed.
I think when we find a fatty liver, more than the FIFO index and the other upcoming markers will be more useful rather than just using the ultrasound or using elastography currently. But those will be more specific because these are dependent on if there is an inflammation and they are whenever a mild viral infection. Even then the elastography report gets
Yes, will be abnormal, but yes, mainly we use elastography whenever whenever the FIB score is high, and once we see that the patient may go into significant fibrosis, and that one we should be more aggressive in saying to him that one of the counselings that I do to my patient is whenever their liver enzymes are elevated, I say, okay, if I take a small piece from your liver and give to my pathologist, as well as if I take a small piece from a person who is drinking alcohol and damaging his liver, the pathologist will say that there is no difference between the two, right? Both pathophysiologically as well as on, say, in the depths of microscopic examination. So for a person who is damaging liver with alcohol, we will say that stop alcohol, otherwise you're going to die. The same is with you. So if you don't reduce your weight and you take it lightly, the same thing is going to happen.
Some male patients are also suffering from.
Yes, there is a condition which we call as TOFI, which is very common in India. We say that they are thin from outside and fat from inside. That is what is called as TOFI. That is, visceral fat is what is important. Now, one of the simple parameters that I said is the circumference of the navel should be less than half of our height. That is one of the things. In women, slightly because the abdominal tone is low and some of them will undergo cesarean sections, so that is not 100%, but there are other parameters like BMI, or there are investigations like CT, MR, or DEXA can give the exact amount of visceral fat that is present in our abdomen, and these things will help. Or a simple ultrasound can sometimes pick.
Sir, the estimate you don't is it available?
In India, it is available not through a proper route, but through improper route. It is available.
And is the fibroscan better than elastography?
FibroScan is nothing but liver elastography. That's a different technology by a different company, and ultrasound we use a little bit different technology.
Sir, I beg to differ on that. The reason being is, in FibroScan, although it's not operator dependent, the reason being very little area of the liver is getting covered.
Yes,
by FibroScan.
yes.
Nowadays, we've got high-end machines which take larger area. Not everybody can afford MR elasto. That's why we can do ultrasound elasto, wherein larger area of the liver is covered. So I think that should be the choice.
I mean, for all the patients, we won't be asking for the elastography now. Common thing is we do ultrasound, right? Once in ultrasound we find fatty liver, I want the thing which gives me a better information.
Exactly, sir. Suppose if you've got a segment 5, wherein the thickness of the liver is increased, and segment 8, where it is free, then if you take the samples from segment 8, suppose, then what's the point of doing that?
See, yeah, I understand, but there are head-on-head studies also which shows that the technology which is used by vibration-controlled elastography gives better results rather than using this shear wave elastography. So, and there are deficiencies in everything. If the patient is quite obese, wherein the waves can't go deep, sometimes there will be falses, but most of the studies, this is what is the case.